Dear colleagues, ladies and gentlemen, it is my pleasure to present on behalf of my co-authors the results of Aquila study. This is the largest phase 3 trial conducted in patients with high-risk smoldering multiple myeloma. These are my disclosures. We know that smoldering or asymptomatic myeloma is a relatively common condition. A population study in Iceland actually showed that 0.5% of the adult population above the age of 40 were diagnosed with asymptomatic or smoldering myeloma. The standard practice for these patients is follow-up, close follow-up without immediate intervention. However, these results oftentimes in end organ tissue damage, what we call CRAB, meaning hypercalcemia, bone lesions, renal impairment, and anemia. There have been several attempts to intercept patients with smoldering myeloma. Lenalidomide with or without dexamethasone has been used in the past. And also there is preliminary evidence that Daratumumab Monotherapy may demonstrate clinical activity and tolerability in patients with intermediate and high-risk smoldering myeloma. Thus, the Aquila study was designed to include patients with high-risk multiple myeloma. You can see the eligibility criteria on the left box. We have to keep in mind that the study was designed in 2015. It was initiated in 2017. And since then, there has been several adaptations in the risk assessment of patients with smoldering myeloma. Patients were randomized to receive either daratumumab given for 3 years, and then the treatment was discontinued, or active monitoring during the same period of time. The primary endpoint was progression-free survival, and this was assessed by an independent review committee, and the endpoint was development of CRAB or SLIM criteria. These are criteria that we use in order to define the evolution of a patient with smoldering myeloma to symptomatic myeloma. It is important to note that all patients at the time of screening were evaluated with sensitive and modern imaging techniques, including PET-CT, or CT scans and MRI, so patients that had occult bone lesions essentially were excluded with this evaluation. Furthermore, all patients were evaluated very thoroughly every 12 weeks with blood and urine studies. Every year, they underwent imaging procedures to rule out the possibility of developing occult asymptomatic bone lesions, and also a bone marrow was performed every 2 years. These are the characteristics of the patients. The median age is 63. This is typical for myeloma. The median time from diagnosis to inclusion in the study was less than 1 year. And you can see other typical features of this disease. Since 2018, we use the Mayo Clinic 2018 risk factor system for multiple myeloma, and these factors include bone marrow infiltration above 20%, monoclonal protein above 2 grams, and the serum free light chain ratio more than 20. We retrospectively assigned these patients to this risk factor according to the Mayo Clinic 20-20, and you can see that two-thirds of the patients had either high or intermediate risk. This is the primary endpoint of our study: progression-free survival. Progression to symptomatic myeloma was significantly delayed in the patients treated with daratumumab. Daratumumab significantly reduced the risk of progression to myeloma or death by 51% versus active monitoring. Furthermore, there were fewer patients who, on the daratumumab arm, who progressed with CRAB criteria and with SLIM criteria. So not only daratumumab delayed progression, but also avoided clinically obvious and important type of progression. Furthermore, there was a survival advantage in favor of patients randomized to receive daratumumab. You can see that the deaths were essentially double, and the hazard ratio was 0.5, and of course, further follow-up will be conducted in this set of patients. And the majority of deaths were due either to progressive disease during or after the study. As far as safety is concerned, daratumumab was very safe. There were no any unusual signals from what we know. There was somehow an increased risk of infection, but these were well treated and reversible. And the discontinuation rate because of daratumumab side effect was low at 5%. We conclude that in this largest prospective, well-conducted study of patients with smoldering multiple myeloma, where patients were very carefully staged to make sure that patients with overt myeloma but without symptoms were not included, indicated that treatment with daratumumab for 36 months was associated with a significant improvement of progression-free survival. Furthermore, during the follow-up period, there was a continuous improvement in favor of the daratumumab arm, despite that the treatment was discontinued at 3 years. Even at 5 or 6 years, there was a continuous benefit from treatment with daratumumab. Daratumumab also prolonged PFS2, meaning the time from daratumumab treatment to progression after frontline therapy for multiple myeloma, and also it improved the overall survival of the patients, and this treatment was very well tolerated. We believe that with this data, patients with high-risk smoldering myeloma may benefit from immediate treatment with daratumumab, and that observation for this particular subset of patients may not be an adequate option. Thank you.
Thank you, Dr. Dimopoulos. We'll keep questions for later. Yes. Dr. Brown, I invite you to present.